Hello students, in today's session we'll be discussing about coagulation disorders. So we'll be discussing briefly about these clotting disorders that you could have. So basic classification of clotting disorders, you have either the inherited disorders or the acquired disorders. So inherited disorders, we know the hemophilia A, that is the factor 8 deficiency, hemophilia B, that's the factor 9 deficiency. These are X-linked bleeding disorders. So usually they have bleeding into the muscles, joints, etc. You could have other factor deficiencies like factor 5, factor 7, factor 10, factor 11 and factor 13 deficiency. These are all autosomal recessive. This is X-linked recessive that is there. Basically when you have the factors, so you have the intrinsic pathway and the extrinsic pathway that is there. So if you have the prolonged PT-INR, so you know the factor 7 deficiency, factor 2 and 7 will produce this. The PT prolongation usually happens in factor 7 deficiency, factor 2 deficiency, etc. Common pathway or extrinsic pathway. Intrinsic pathway is the APTT, that is the factor 8, factor 9, factor 11 all come in the prolonged APTT deficiency that's there. Combination both PT and APTT can be deficient when you have a factor 5, factor 10 and factor 2 deficiency and a fibrinogen deficiency, both PPT and APTT is prolonged. Important things that have to be done other than the factor assays, we will require to do something called as a mixing studies to identify any acquired inhibitors. The acquired coagulation disorders very commonly we see in liver disease, you can see it in DIC, then could be due to acquired inhibitors like aluminization disorders, postpartum etc. You can see these disorders. Treatment basically is to support these factors. If it is specific identified factors, we have to supplement the factors. Otherwise, fresh frozen plasma and cryoprecipitate has to be given. So let's discuss some of these in detail. Coming on to hemophilia, as we discussed, hemophilia A and hemophilia B. So these are X-linked disorders. So you have the factor 8 and factor 9. Common, 1 in 10,000 males gets affected, and women are asymptomatic carriers. Women can get hemophilia if there is a lionization or a carrier woman marries a suffering male, or the woman has a XO, that is a lionization phenomena that could happen. So the clinical manifestations of hemophilia depends upon the factor levels. So if the factor activity based on, if the factor activity is less than 1%, then they will have severe manifestations. 1 to 5 manifestations they can have moderate, and if the percentage is between 6 to 30% of the adults, they will have very mild manifestations. So severe would be spontaneous bleeding into the joint, spontaneous into the muscle, etc. Moderate where after trauma bleeding that could be happening, and mild is only after surgical incisions, etc. they could happen. Most commonly they bleed into the joints and muscles, but they can have skin soft tissue bleeding also, oronasal bleeding, menstrual bleeding. Sometimes they can have central nervous system bleeding also. The chronic bleeding into the joints can lead into arthrosis, hemarthrosis, and that can cause joint damage, and what we call it as the hemophilic pseudotumor formation can happen. So confirming APTT is prolonged, and then you can do the factor assays and genetic testing that is there. Very importantly, the treatment is factor replacement, that's the main therapy. Remember, factor 8 has a half-life of 8 to 12 hours, factor 9 has a half-life of less than 24 hours. So it's very important that we maintain the factor levels anything more than 1%. So we have to assess the severity, and our aim is to maintain above 1%, preferably more than 6%, that is what we want to maintain, that is there. So what is the dosing formula? For factor 8, the dosing formula is target factor 8 minus the baseline factor into body weight into 0.5, that is for the factor 8. The factor 9 is the target factor 9 minus the baseline factor 9 into body weight into 1. So that is where we have to maintain. So, but remember, the target is to maintain a minimum about 1%. Other than factors, you can use certain drugs like the Desmopressin, that is the DDAVP, which basically raises the factor VIII and von Willebrand levels. So, it can be used for mild cases. Antifibrinolytic therapies like tranexamic acid, etc., can be also used. There. Now, with recurrent transfusions, there are allo antibodies formed against the factor VIII and IX, and that is what we call it as the factor inhibitors. So, these can be diagnosed by what we call it as the mixing studies. So, it requires these factors, how much ever we give, they will not be able to improve this. So, we will have to either bypass agents are there, that is the activated prothrombin complex, or the recombinant factor has to be used in these conditions. Steroids may be required. Lot of new drugs are available for the treatment of hemophilia. The one drug that has come is emicizumab, which is a bispecific antibody, bypasses the need of factor VIII and it's once monthly dosing. Gene therapy with the adeno-associated vector has been successful, and these factors have been pegylated. So, pegylated factor VIII, pegylated factor IX, or the IgG1 Fc factor IX, or albumin reduced dosing frequencies can help by one is decreasing the dosing frequency. Very important, these patients with recurrent transfusions are vulnerable to get hepatitis B, hepatitis A, HIV, etc. So, screening is mandatory, and long-term hemophilia, very importantly, we will have to advise them of genetic counseling. Also, hemarthrosis and other complications have to be explained. Now, hemophilic carriers, important, females. So, during pregnancy, usually nothing happens, mild amount of bleeding might be happening, and that can be circumvented. Again, the baby has to be monitored. Coming on to the factor XI deficiency, it is an autosomal, rare autosomal bleeding disorder, occur in 1 in million. Here, the factor, normal factor XI levels is around 70 to 150 units per deciliter. If it is less than 1 unit, it can manifest with bleeding. So, again, here, usually post-operative bleeding is what you see there. Treatment is fresh frozen plasma and cryoprecipitate and supportive therapy that you give. Rarely you could have other bleeding factor disorders like the factor combination disorders, multiple clotting factor disorders, which can manifest. It can be inherited, especially in the Ashkenazi Jews population, so we have to identify and manage it. Various mutations, especially in the LMAN1 and the MCFD2, genetic mutations are usually associated with multiple clotting factor deficiencies, especially factor V and factor VIII deficiency that is seen very commonly in these patients. So, we will have to assess in that. Other important condition where you have multiple clotting factor deficiency is the vitamin K deficiency, where you could have factor 2, 7, 9, 10 and fibrinogen, protein C and S deficiency. Could be acquired due to liver disease or could be genetic due to the mutation in the gamma carboxylase gene that is there, or the vitamin K epoxide reductase gene. So, these two genetic mutations can result in this. So, these patients would require cryoprecipitate and vitamin K supplement could be seen. Acquired bleeding disorder, which we very commonly see, is DIC. So, DIC is disseminated intravitreal coagulation, which is acquired, where there is thrombosis as well as coagulation resulting in a blockage of various vessels, microvasculature. Simultaneously, there is bleeding that can happen. DIC can be triggered due to various causes. Most important cause for DIC is sepsis that you see, puerperal conditions, postpartum obstetric causes like abruptio placenta, amniotic embolism, some malignancies, especially the mucinous carcinoma of the pancreas. So, here you have widespread clotting as well as bleeding. So, the patients can have ecchymosis, they can have thrombosis of organs, has a very high mortality rate, almost around 80%. So, you have to have a clinical suspicion. You look for renal failure, cystocytes, as well as the patient who has a bleeding and clotting problem together. Thrombocytopenia is there. Basically, there is a deficiency in the various clotting factors. So, we have to supplement them immediately. Also, you have the TTP. TTP is a condition where you have the ADAMTS13 deficiency. They have no coagulopathy, but they have neurological manifestation that is there. And then you have the HUS that is there, which is manifesting predominantly with renal failure. So we will have to monitor the platelets, monitor the clotting factors, supplement it adequately, treat the primary cause. Despite of good treatment, DIC causes a very high mortality that you would see there. As we've already discussed, vitamin K deficiency in liver disease, very common. So you have the factor 2, 7, 9, 10, protein C and protein S. It could also happen due to malabsorption, chronic pancreatitis, etc. Prolonged PT is what you see there. So you have to correct with IV vitamin K, and if it's severe bleeding, then you have to give fresh frozen plasma or cryoprecipitates that could be seen. The other problems of bleeding in a patient with liver disease could be secondary to thrombocytopenia also. Also, you could have deficiencies of certain other factors, like as we said, the protein C, protein S can be there. So which may be difficult to diagnose. So generally a patient with liver disease, you might require factor transfusions, we require FFP, cryoprecipitates and platelet transfusions also. Acquired coagulation factor disorders or the inhibitors can happen. Now this commonly happens in autoimmune diseases or sometimes post-stake envenomation or sometimes on immunomodulatory therapy, these could be there. These patients would generally require bypassing agents, that is the activated PCC or the recombinant factor levels should be there, and this can be diagnosed by doing mixing studies. You will have to rule out lupus. One of the commonest causes is lupus. So if lupus is there, then we'll have to treat the lupus. You may have to start them on steroids, immunomodulators, and the patient might require rituximab also in certain cases. Students, in today's session, we briefly discussed about some clotting disorders, hemophilia and other diseases.